And today we have Dr. Maureen Nash, who is going to be presenting on managing challenging behaviors in residential care settings. This is brought to you by Jackson County and Josephine County Older Adult Behavioral Health Specialist. Our training etiquette and CEU details, so please mute your mics. Utilize chat for questions and comments. You will receive a follow-up email with slides, a link to the recording, and any training materials and surveys for the CEUs. The recording will be posted on our YouTube channel, and live attendance is required to receive the CEUs. You must complete the NASW CEU survey to receive CEUs. That will be included in the email that goes out. And then PSU hopefully will send out a survey about today's training. We ask for your feedback and comments. Once you complete PSU survey, you can download a certificate of completion. We are the Behavioral Health Initiative for Older Adults and People with Physical Disabilities, which was launched in 2015 to meet the needs of older adults and people with disabilities by improving timely access to care from qualified providers who work together to provide coordinated, quality, and culturally responsive behavioral health and wellness services. Specialists engage in collaboration and coordination in systems of care. We help build knowledge capacity through free workforce development trainings like today and community education. We also provide free complex case consultations. Oregon Health Authority funds and supports 24 specialists statewide, and our website is oregonbhi.org. Our upcoming training, Hope for the Best, Plan for the Rest, Navigating a Life-Changing Diagnosis, is November 13th from 9 to 11. And we will send out the flyer for that as well in our follow-up email. And as I said before, you will receive a link to the recording and slides and any materials that Dr. Nash shares with us today. And let me just click end here. Okay, and Dr. Nash, if you'd like to go ahead and share your slide deck. Thank you.
Can you see my slides?
Not yet.
Oh, that's weird. Okay. Let's try that again.
I clicked allow multiple presenters to share. I hope that's what was needed.
Can you see my slides now?
Yes.
All right, I take that as a yes. So speak up if there's a problem. And
yes, we see your slides. Thank you.
So managing challenging behaviors in residential care settings in 2 hours or less. There are no financial disclosures. All opinions expressed are solely mine and do not represent any other organization or anyone else. And I'm an internal medicine physician and a psychiatrist. Currently, I'm working part-time as the clinical psychiatric director at the Native American Rehabilitation Association of the Northwest, which is a federally qualified health center here in Portland that serves mostly a Native American population, although anyone who comes. Previously, for about 10 years, I was the medical director at Providence Elder Place, PACE, Program of All-Inclusive Care for the Elderly. And then before that, I was actually the medical director at the Tuolity Center for Geriatric Psychiatry, which doesn't exist anymore, sadly, but was a referral center for people with challenging behaviors from the Pacific Northwest. I mean, we took care of people sometimes from Alaska, Northern California, Idaho, and Nevada, and as well as lots of people from Oregon and Washington. So I will just preface this all to say my experience has been mostly with 3 different groups of people who have serious mental illness, usually in a decompensated state, with the goal of getting that person into a compensated state. And then also with people who have dementia with really out of control behavior such that they need an acute hospital stay, which used to be easier to do in Oregon and is now sadly almost impossible to do. And then the third group of people who I have extensive experience with is older adults, 55 and older, living in community-based care. And you have to be very impaired ADL-wise to meet criteria to be in a PACE program of all-inclusive care for the elderly, which is a Medicaid, Medicare program. And our goal there is really to care for people in the home where they're living. And so that is a really different viewpoint than working in acute care or working in hospitals or even in a clinic, right? There you're like treating people's symptoms and their underlying disease, or trying to figure out what that is. But the 10 years with Elderplace PACE, I really took our premise was your quality of life is going to be better if we can keep you out of the hospital. And I actually firmly believe that. Hospitals are great if you need it, but boy, wouldn't it be so much better if we could help people stabilize so they didn't need it. And the reason I'm going into all this is so this is where my experience has been. And so that everybody who talks is always going to share from their experience base. We all read lots of things, or many of us do. But what we end up believing is what we've seen work in our, right in front of us. Everybody kind of believes what they see, which is why psychosis is so powerful, because people believe what they see. So hopefully this session will provide frontline staff and supervisors with practical evidence-based techniques for recognizing, responding to, and managing aggressive or resistant behaviors with confidence and compassion. And I'm going to review some de-escalation strategies, some communication best practices, and environmental adjustments, all designed to reduce triggers of behaviors and prevent escalation of behaviors. Because boy, that is so much easier than actually treating behaviors once they occur. And so I have a number of cases spread throughout, and I do encourage participation. But if this happens to be one of those really quiet audiences and people don't speak up with questions or add in to the case discussions, then the good news is I will just talk. The bad news is I will just talk. So, and that was a lot more background than I usually do. So, this is just a very brief workshop. And I just want to point out what I think you guys know. And I can't believe I left it off the list. The number one thing on this list should be the older adult behavioral health specialists. Oregon is very lucky to have such a great program. It's a very unique program. And in my opinion, it is essential because we don't have programs in this country where behavioral health and older adult services work hand in hand very often. And So just like I'm speaking from my experience, the challenge is lots of people have problems that need help from both realms, but we don't have good ways for those realms to talk to each other. And so we don't have great sort of structure to support what people, older adults with behavioral challenges need. And so that's what the older adult behavioral health specialist program is designed to address. And I think it really does in a very sort of person-specific way. There's also, local experts. There's the Crisis Prevention Institute and all sorts of other sort of crisis, de-escalation kind of trainings. TIPA Snow has trainings specific for dementia, lots others. So my first point, and if you take nothing else away from today's training, this would be a good one. What is behavior? I mean, behavior is always how people communicate to us. And for older adults who have any sort of cognitive challenge, which would be people with dementia, people with substance use disorders, people with learning disabilities, people with developmental disabilities, people with mental illness, serious mental illness, people with strokes, people with people with Huntington's, people with MS, anything that affects the brain. Those folks, their behavior tells us lots more than their language, than their words. And this is a really important concept. And let me be clear, I am not saying that we ignore what people tell us, because that is illogical and nobody actually does that. But the mistake I find that people make is they pay super attention to what people say, when that is not the most powerful form of communication in any way. It's the behavior that is communicating to you. And if you can not get distracted by the words that people say, people's explanation of why they're doing something, people's, people telling you what they want or what they need. And again, I'm not saying you ignore that, but for people who have brain disease, brain disorders, their ability to use language is often impaired, and often impaired gravely. And so instead of responding to what people say first, responding to people's behavior first is my recommendation. Because people's behavior is telling you something. And most often, a behavioral disturbance is telling you about a person's needs that are not being met. So, people's physical needs, such as pain or discomfort, people's environmental needs, such as, too much distraction, too many things going on, so they can't really focus on whatever it is they need to focus on. People's emotional challenge, they're sad or they're happy or they're anxious. People's social needs. We are social beings, and it's actually the number one thing in healthy aging is having good social relationships. And that can be friendships, that can be family, that can be colleagues. But that social part of life is super important. And one of the things that in a facility, there's lots of challenges for the residents, right? There are lots of things that are out of their control in ways that are artificial. And almost no one has lived you know, in a way that will prepare them to successfully live in a residential care facility. So, and if you know, some of the, like, one of the saddest studies I ever read was about people living in a nursing home. And they, in general, they had, you know, about 90 seconds of non-caregiving physical touch from another human being per day. 90 seconds. Like I can't, that one study had really a profound effect on, and I was like, wow, like, well, no wonder people are having a challenge. I mean, that is, it's really important, shaking people's hands, you know, for the appropriate person, maybe touching them on the arm, whatever, you know, but touch, or at least physical proximity, that is more socially oriented and less focused on feeding, dressing, changing, toileting, you know, that isn't sort of task oriented. So this is a really important thing. And so I'm going to come back to this point later, at least once. And here's the therapeutic approach. So Sarah Feudel, who's an occupational therapist, and myself, along with many others, Maria Schindler, who's an RN, and then the great staff at the Tuality Center for Geriatric Psychiatry. This was sort of the therapeutic approach that we all developed together. And this is, in particular, this sort of diagram is from a book that Sarah Feudel and I wrote and edited along with Sue Rose, who is a PMHMP and gerontologist, PhD gerontologist. So here's the therapeutic approach. And we developed this approach and outlined it really in relationship to dementia, but it works for everybody. So you don't have to have dementia to need a therapeutic approach. And so the therapeutic approach to really behavioral disturbance, is the first thing one has to do is identify and assess the cause. And do we ever really know 100% what the cause is? No, we do not. So we have to take our best educated guess. We have to think about it. And some people are more natural at this than others. And that's sort of why, and it's unrelated to education. They're just some caregivers who, either because of where they grew up or how they grew up, or just something about their life, they get it. They seem to really be able to do this naturally. You can go to as much schooling as you want, and some people just are not so good at this. But the number one thing to do when there's a behavior that is causing challenges to the person or those around them is, I really am a big fan of the ABC approach. Describe what happened. Does everybody know about the ABC approach? Antecedent, behavior, consequence. So those are like artificial words, but what was going on? Kind of create a picture for me, or a little short movie for me, of what was happening before the behavior occurred. Was it shift change? Was there loud music going on next door? Was there somebody down the hall screaming? Did somebody walk into the person's room? Did the person walk into somebody else's room? What was going on prior to the behavior? And then for the behavior, it's so important. And this is a real challenge, because who has time in residential care? Is actually not labeling the behavior, but describing exactly what the behavior was. And so I've gotten referrals for, sexually inappropriate behavior. And when I asked, well, tell me what happened, and it was an older gentleman who was peeing in flower pots out in the waiting room, in the lobby, not the waiting room, but the lobby. And you know, our treatment team, we all looked at each other and we were like, well, that's great. He's peeing in flower pots. I mean, he's not spraying the walls. He's not peeing on the floor. This is fantastic. But because he pulled his pants down to pee, which not everybody does, you know, people, and his penis was there in full view. People were like, this is sexually inappropriate behavior. And I was like, no, this is a man who needed to use the bathroom. But that's it. So labeling it isn't helpful. Describing it is helpful. And teaching people to do that is so important. People use the word agitation, they throw it around, and that is like the least useful word on the planet, in my opinion. Physical aggression is useful, especially if you tell me hitting or throwing, or, you know, if there's a weapon involved, heaven forbid, whatever. Verbal aggression, you know, racist comments or rudeness or screaming, you know, whatever the verbal, or is it psychomotor agitation? Is it restlessness? Is the person pacing? You know, what is the agitation? Is it aggression, or is it psychomotor agitation, you know, restlessness, or is it something else, right? Describe it. Agitation is a sort of meaningless word because it can mean so many different things to so many different people. And then the consequence, what did people do after or during the behavior, and how did it work out? So the ABC. And if you can actually get really good ABC info for a behavior, then you are like in like Flint, because at least you can come up with an approach. And if we come up with an approach just based on the label, they were depressed or they were anxious or they were agitated, if you just get that one word label without the ABCs, you are nowhere, because all the things you do next could be totally inappropriate. Even though they're well-intentioned. So this kind of ABC approach is key, very key. So first column here, you want to identify unmet physical and psychological needs. And that is super important. And I really want to emphasize, even when people can speak, right? There's lots of people who are not mute. Most people, in fact, doesn't mean they can tell you in words about their physical or psychological needs. Because even the best of us, the more stressed we get, the less able we get to give you useful information verbally. And that's why you have to pay attention to the behavior. And the more impaired a person's brain is, the less helpful their language is. So the people to listen to what they say and really totally focus only on what people say, or mostly on what people say, is for the people who don't have any brain problems. But for all the rest of us, you need to look at our behaviors as well as what we say, and you need to believe the behaviors more than you believe the words, even though you have to look at all of it and include all of it. Okay. So you want to identify physical and psychological needs. You want to identify environmental causes. You know, is it all happening around 3 to 5 p.m. every evening? I mean, what happens around 3 to 5 p.m.? Well, there's lots of things. There's often a shift change. It's almost dinner time, or it is dinner time. People are tired. People who have brain problems do not have the ability to appropriately rest. And so some schools, you know, used to do like a late morning nap or a nap right after lunch And I actually think many of us would be better off with a 20 to 30-minute rest period, late morning, early afternoon. A lot of what people describe as, quote, sundowners, unquote, which again, another one of those kind of useless phrases, because it doesn't really tell us anything about actually what's happening. A lot of that is because people are unable to rest appropriately. Either they didn't sleep well last night, or they slept well, but they were sort of very active in the day. And so in the morning, or they were awakened before they were really ready to be awakened. So people need to rest, and people whose brains are impaired are not actually great at doing that. So that's just an example. Look at the environment. What's going on? Look for environmental causes. And so one of the things we know as people age, vision changes, ability to perceive colors and color contrast changes, sensitivity to noise changes. People become hard of hearing. So there's lots of environmental things that recognize psychiatric symptoms. And by that, I mean depression, anxiety, and psychosis. And so for depression, there's a lot of depression in the world that is not major depressive disorder, that is not a psychiatric illness. And so the approach is really different depending on what you have. So if people have a psychiatric illness, that should really be diagnosed and treated by somebody who knows how to do that. But depression and sadness and grief, which are not uncommon, there's a lot of reasons you might be sad. Like, it's an appropriate reaction to certain things. Somebody died, or you're thinking about somebody you love who did die. So if it's sadness, sort of you approach it one way. But sadness, you have to recognize, sometimes is a normal, natural, appropriate reaction. And the same thing with anxiety. I mean, 0 people who don't have anxiety survive childhood. Anxiety is the only thing that keeps us alive. Anxiety prevents us from walking off cliffs. It prevents us from jumping into a fire. It prevents us from touching the hot stove and then just leaving our hand on it. Anxiety is adaptive, but it can be out of control. So when somebody has anxiety, you have to analyze, are they anxious because there is something to be anxious about, in which case, you have to have more systemic kind of addressing of it. Are they anxious inappropriately because they have a brain disease? Then you need to treat the brain disease. So, and then psychosis. What is psychosis anyway? So there's a lot of really interesting misunderstandings about that. But psychosis is a group of different symptoms. So one of the symptoms is auditory hallucinations. And so I'm talking, you guys are getting information through your ears that is going and is processed. Then it goes to your primary auditory cortex, which is in your brain. And then the information is processed, and then it goes to your secondary auditory cortex, and the information is processed, and the secondary auditory cortex tells the whole rest of your brain what you just heard. And obviously it happens like that, right? Just happens very quickly. But an auditory hallucination is when your secondary auditory cortex gets activated and tells your brain what you heard, even though nobody else heard it. So, of course, you believe it, because it's like everything else you've ever heard. You heard it. It's real. Auditory hallucinations are not made up in any way. They are the secondary sensory cortex telling your brain that something happened. You heard something, you saw something, you felt like a touch of something, even though those things didn't actually happen. And so that's why a person who's having those symptoms, their biggest challenge is figuring out what's real and what's not real. And that's something that medications are pretty good at helping. Many times you can make hallucinations go away with the appropriate medication, or you can help people kind of get better at telling what really happened from oh, I just heard that, but it's probably not. It's probably my hallucination, right? Some people actually are able to about 50% of people are able to recognize that. The other 50% of people, they believe what their brain told them, like all the rest of us. Everybody believes what their brain tells them. Okay, so the other kind of psychosis is disorganized thoughts, and that's where you can't really process information. We usually know about that because of people's speech. Their speech doesn't make any sense. It's from topic, all over the place, or it just like word salad kind of thing. So when you have these kind of behaviors, this whole group of things, I'm a big fan of utilizing behavioral rating scales for two reasons. Number one, then you know what behaviors you're to target. And number two, you can tell whether or not you're making a difference. You can tell how severe it is. And when there are behaviors, that's when you think about, has there been a change in the person's cognitive or functional abilities? And so sometimes the right answer is, find an OT or a behavioral analyst or somebody to help you, or, call the PCP or the mental health person if they happen to have one. So that's the first step. And that's the most important. This whole process is the most important because this is how you select an intervention based on your assessment. And then you apply the interventions. And the key thing here is if you go to you do a Google search or a YouTube search, people are going to talk about interventions. But the key part is you have to match the intervention to your assessment. And that's why the assessment part is so important. And because time is so precious and we just don't seem to have enough of it, it often kind of doesn't get enough attention. So I'm going to talk a little bit about interventions here during my talk, but not so much. There's lots of stuff out there on the interventions, but I will tell you, in my opinion, we aren't able to take enough time to do this very first part, identifying and assessing the causes. And it's really hard to do. And so that's why like a meeting of the minds, multiple different people talking about it. So, and the bigger the behavior, the more troublesome the behavior, the more time you should spend on this first part, this very first part. And our natural thing, and I'm as guilty as anybody, our natural thing is to intervene right away. And, there are times where intervening right away is the thing to do. But most of the time, you really need to get the right intervention. And to get the right intervention, you have to go back to step one. Okay. So you've selected an intervention and then you've applied the intervention. And the most common kind of interventions are caregiving approaches, adapting the environment, evidence-based interventions such as sensory interventions, activities, communication intervention, and staff training. Now you will notice that caregiving approaches and staff training they overlap quite a bit. What I will tell you is there's a little bit of evidence for adapting the environment, and there's a little bit of evidence for sensory activity and communication interventions. But really there is most evidence for is staff training and changing caregiving approaches. Can anybody tell me, so this is your chance to unmute and pop up your hand. Can anybody tell me why staff training and changing caregiver approaches might be the most effective? Yes, Regine,
but that's okay. It's kind of like we all get into like a one track mind. What used to work will still work, and we get focused on one area. But if you bring in a staff change, they also kind of see what the outside environment brings into the inside environment. So changing of the guard is what we like to call it, gives new opportunity for eyes to observe something different. And that usually helps redivert or retransition a plan.
Right. Yep. So, and that's sort of kind of changing the caregiver in a way to change the caregiver approach. And that can really make sense, especially if things aren't, people keep trying and it's not getting better. Excellent. And the other reason that staff training probably has the most evidence for it is because, especially in mental health, we really focus on helping people change themselves. But guess what? When your brain is really broken, you're not going to be able to change yourself. You might want to change, but your ability to change is going to be limited. Therefore, the people around you need to change in order for your behavior to change. And I hope that made sense. So that's, in my opinion, that's why of all of these things, staff training and training around caregiving approaches has the most evidence for it. All these other things do have evidence and they're really important, but they are less important, less successful than actually training your staff and focusing on caregiver approaches. And sometimes this is an unpopular viewpoint because we just want people to act right and fix themselves. And I understand that. It is a very natural feeling, but it's not helpful. Because even if people want to change, if their brain is broken, they are going to have problems learning new things and learning to change. But people will change in response to you're changing your approach. Okay, so then you've applied your interventions, you want to monitor outcomes. And so that's kind of where, again, a behavioral rating scale or a quality of life rating scale, monitoring, checking in with your staff. Do they have the training they need? Or how are they feeling? Because obviously, how your staff feels impacts how everybody around them does. You want to individualize interventions. You want to use a person's preferences. And then caregiver report. Really, the closer the person is to the resident, the more weight their report holds. But again, you need to train them in the ABC method so that the information that your direct caregivers give, it can be the most helpful to the rest of us to try and help the resident. So that's the therapeutic approach. And I think of this really as a person-centered approach. And the goal is for us to identify the world that the resident is living in and not to drag the person, the resident, into our world. And heaven knows there's lots of things in the real world who would want to be oriented to anyway. So you want to identify the world in which the person is living, and that's person-centered care. That's where it happens, not in sort of, the here and now. It's October 9th, 2025, and we are in wherever we are. That's less helpful. People with dementia and other brain diseases often cannot change, but staff members can when they're not super burned out. And I don't know, I'll just speak for myself, but the COVID pandemic was very hard on those of us who worked in residential care, and really, I think a lot of the world seems to have just moved on. But I just think about, there's one facility that was probably the best facility in Portland, Oregon, in my opinion, and it closed. The state closed it early on in the pandemic because of multiple challenges they had, because they cared for the most challenging people. But one of the things that really struck me about that facility was they had 2 young caregivers die of COVID. And I always think about that, if I was 16 or 18 or 25 working in a facility as a direct caregiver, and I had peers the same age who were ostensibly very healthy people, and I saw them die, like what the impact of that it was and still is. Like, I don't think that's something people like just get over. That's a big deal. And I really think anybody who was a caregiver during COVID, if they're not burned out, they're still deeply impacted. And so lots of people are. So enough about that. It's important to respect people's personality. If you can actually find out what people like to do, what they used to do well, what they hate, what they're interested in, if you can get that kind of background information on a resident, that is golden and very, very helpful. I like to say the most important thing to know when somebody moves in is, when they shower, do they like use a bar of soap, or do they like to soap up a washcloth? How do they clean themselves? Like, if you're going to help bathe somebody, that is, in my opinion, one of the number one things to know about someone. And lots of people, by the time they move into a facility, can't tell us. But that's the kind of really important detail if you're going to bathe somebody successfully, knowing what they like, what they don't like, what they're used to. And then this is always a challenge, for some people more than others, because I think there's a little bit of a sort of general disposition, but retaining composure, having non-reactive responses. And so, we had a fellow, he's 84 or so, and he was on our unit, and he spent all his days, like, he would use his hands to kind of rub the floor and the walls. And if you talk to him, he was like, I gotta work. And he even took the molding off the walls at one point, and not with any tools. So, and the CNAs developed a great intervention. They gave the man a washcloth. And it was really interesting because some families were really upset about that, but the man really liked it. And we told the man that Fridays was payday, and, you know, we would make sure that he got, you know, he got paid so that he could get his needs met. And that was us entering his world. The man, it turned out he'd been in the Navy, and anybody who's worked on it, who was enlisted in the Navy knows you spend a lot of time mopping and cleaning. Like that's a big thing on a ship, and you do it all the time. And it's actually super important. So he wanted to work, and he had this impulse to work all the time, and that's what he wanted to do. And really what was person-centered for him was helping him work. Now, obviously, we were not depending on him to actually clean anything, and we cleaned everything as well, but it helped him to have things to do that he could do. And that is person-centered care. And you get it in your care plan so that when the inspectors come along, they get it. So is dementia a cognitive disorder? Yes. Is it a behavior disorder? Yes. Does it involve the loss of functional abilities? Yes, by definition. Is it a complex neuropsychiatric disease describing brain failure? Yes. Yes, it is. You know, we think about heart failure, but I think really progressive causes of dementia are brain failure. And sometimes I think that can be very helpful for families to think about things that way. Because it really helps put it all in perspective. And there are lots of other neuropsychiatric challenges that cause combative behaviors or disruptive behaviors. So this slide, I'm just showing this slide so you can see my somewhat nice little straight lines, somewhat straight lines. Those black lines are mine. This slide just shows that psychotropic med use, so meds for psychiatric meds, are prescribed at quickly increasing rates before there's a diagnosis of dementia. And this is because, in my opinion, psychiatric symptoms are the first sign of dementia before we successfully diagnose it. And so this is true for antipsychotics, it's true for antidepressants, it's true for anxiety meds, and it's true for sleep meds. And those are the four most common behavioral signs of dementia: aggression or psychosis, depression, anxiety, and sleep problems. So, all right, so here's another audience participation question. So I'm going to tell you about Ralph. So Ralph walked up to the nurse's station, or the room where the phone was, kind of like a reception desk. And Ralph said, "My car's been stolen. My car's been stolen. You know, what am I going to do? I got to go out there and look for it." And Ralph had dementia, and we didn't really want to let Ralph out into the parking lot. Ralph was 6'2". He was a pretty strong fellow, quite ambulatory. And as the first person he talked to, staff-wise, was trying to say, "Ralph, you don't have a car here. Your car wasn't stolen." And Ralph would just got more and more upset because his car had been stolen, and he needed to do something, and he needed to do it right now because it's very important, because how could he live without his car? You know, he needed to go to work, he needed to take care of his family, he needed to, you know, do all the things you do in your car. And so he was getting more and more escalated. And so by this time I was there. There were a couple other people from the staff who were there, because we had, and of course, when was this happening? Like 4:30, right before dinner. So lots of staff were kind of busy with that kind of thing and getting other people into dinner. And so Ralph just was very agitated. So can anybody give me some suggestions or thoughts or what to do next?
Call an inside line and let him make a police report.
You are brilliant, or maybe you heard me talk about Ralph before, because I do talk about Ralph a lot. Yes, that was exactly, we had this brilliant CNA, and she went around the corner to the med room, and she called the phone right near where Ralph was, and she said to the person who answered the phone, hand the phone to Ralph. So, and what did she say to Ralph? She said, Ralph, I hear you have a stolen car. This is Jane from the police department. I'm here. I want to make I'm going to take a report about your stolen car. And he was like, oh, yes. You know, he was like on it. So she said, what kind of car was it? What color? How many miles did it have on it? When's the last time you drove it? What do you use the car for? How many doors does the car have? And she just asked him all these questions, and she just kept asking him questions about his car. I don't know how because you can now see those are the only ones I could think of, but she kept him, went on and on just asking him questions, and he answered the questions until finally he like took the phone and he stared at it, and he said, this lady is crazy. And he handed the phone to the receptionist, and one of the CNAs who was standing right there said, Ralph, it's dinner time. Let's go eat. And he said, okay. And he went and he ate. And we never heard about the car again. And of course, his car wasn't there. He didn't drive his car. But that is person-centered. It's entering his world. It's meeting his need, which was his anger and fear over his car being stolen. So it wasn't addressing his anger and he was by that point pounding on the desk. It wasn't addressing that directly. It was addressing his natural reaction to something. Just so happened the something wasn't real, but his reaction to it was natural. And I mean, most of us would be pretty distressed about our car being stolen. And he actually had he went up and he was like, I got to call the police. I gotta go look for my car. Like that, if your car was stolen from a park, that's the thing to do. So his reaction was normal. It just wasn't helpful to the situation at hand. And so this CNA, one of the most brilliant people I ever met, named Sue. Yeah, so that's Ralph. Okay. So thank you. So let me tell you about Robbie. Robbie was a retired law enforcement person, and he was from a more rural part of Oregon, and he paced around. He had a terrible tremor. He had a really small gait, and he didn't really speak. And he's kind of a broad fellow and muscly-ish, and he always frowned. And people got really afraid around Ralph and intimidated. And all he did was walk around. What might people do?
Offer him a seat.
That's a great thought. Offer him a seat. He didn't want to sit. And if he did sit, he would sit for about 30 seconds and then he'd get up and he'd just pace around, but not like a fast pace. It was, he didn't have Parkinson's disease, but he had kind of some symptoms like Parkinson's disease. And he wasn't on any meds at all, actually. Yes.
Well, I would probably observe to see what time of day or evening or something like that is occurring. And then I would kind of watch body language or sight movement to see what he's looking for or the absence of movement. And then kind of approach it that way.
Excellent. So really trying to figure it out. And I will tell you, Robbie was another, I thought he had a very sad case, but he didn't really look at anything and he didn't really look around and and it happened all the time. He just, that's all he did, was like this walk around with this really sort of Parkinsonian kind of gait, you know, small steps, and he had tremor and he didn't really look at anything and he didn't engage. So we had the family of other people. One family came up to us and they were very upset about Robbie because he was quote unquote scaring my mom. Another family came up to us about Robbie and said, "Oh, I know him. You know, my sister lives in the same facility with him, and the staff at the facility told us that we should never talk to him and we should avoid him because he's really dangerous." So he had spent the last 2 years at a facility where staff isolated him and encouraged everybody else to isolate him. And if you tried to make him do something, he could get very aggressive. And then we had a third family come up to us and said, "Shame on you for medicating this man. Look at him. He can't even hardly walk. He can't talk. I can't believe you've done this." Now, this, of course, is the world of HIPAA. So we couldn't say to this third family, "Well, this man is actually not on any medication." You can just say, "Thank you for your input. We're working to help this man just like we're working to help your loved one." But people assumed this man was heavily medicated. And so Robbie taught me quite a bit about a lot of different things. And what did we do with Robbie? Well, we got more history. And so Robbie, besides being a law enforcement person, had been an amateur boxer. And so he'd had a ton of head injuries, probably in both realms, more so in boxing. And so we ended up putting him on a dementia medicine for Parkinson's disease, even though he didn't really have technically Parkinson's disease. And with that medicine, when we offered him a seat, he actually would sit down for short periods of time. And we had one caregiver who didn't feel intimidated, and that person would go and spend some time with him like for 10 minutes at a time, and that person would just talk to him about, just tell story, just talk, not asking him something, not asking him any questions, nothing like that. And then we happened to discover that he really liked this one kind of music. So we put that music on in his room during the day. And then we could walk him to his room and he would actually sit down, maybe listening to the music. It's not quite clear what he was doing because he didn't talk to us, but he seemed much calmer. And he occasionally smiled. And that was improvement for Robbie. And he also stopped being aggressive with cares as long as you told him what you were going to do before you did it. You did it really slow. You let him do as much as he could. And you really did minimize how often you gave him direct personal care. And that's what worked for him. But that Robbie taught me a lot too.
So Dr. Nash, I was kind of thinking when I said offer a seat, I was kind of thinking of kind of meeting him where he was, or maybe walking with him to just try to share, bits and pieces of communication and see what the response would be.
Excellent. And that's exactly, yes. Before until we really discovered the music, that we didn't really get any sitting very much. He would sit down briefly for meals, but he did best if he had meals with 1 or 2 people in the room. He did not do well in the dining room where everybody was. So he needed kind of a special meal plan, so to speak. Yes. All right. So what type of evaluations to consider? Really, I'm a big fan of occupational therapy. Anybody who's heard me speak knows that and occupational therapists are really good at assessing what ADLs and independent ADLs a person can do and which ones they can't. And many OTs are very creative problem solvers. So if you have a good OT, they're worth their weight. Behavioral analysis consultants can also be helpful. If you have behavioral analysts who have experience working with dementia, because most of their training is with people with mental illness, and really they are very trained very heavily to talk to people and just help the person with what the person identifies. And that is less useful with this population. And then, of course, my favorite, the older adult behavioral health specialists. All right, so the NPI. So the neuropsychiatric inventory, I'm just going to review this briefly. It's a tool, it's free, it's online, there's trainings about it. It has lots of descriptions of what these words are: elation, euphoria, hallucinations, appetite, eating disorder, sleep. So those are all words that some of which are pretty helpful, but actually the neuropsychiatric inventory, if you look at it, it asks like 3 questions for each one of these. And it helps define what these words mean. And that gets back to that ABC thing. Because a lot of people, it's really interesting to me, a lot of people will use the word delusion when they mean hallucination, or they'll say hallucination when they mean delusions, or they'll call something agitation when I would call it aberrant motor disorder, or I might call it anxiety. But the key thing about the neuropsychiatric inventory is this way, when you're doing like ABCs, everybody's going to mean the same thing when they describe one of these. And so it is not the only tool. You don't have to use this tool, but it is a tool. It is very useful, and it helps define what these things mean. And then you can actually have a really good, process, because everybody's using the words to talk about the same thing, which at the end of the day is the purpose of language and communication. But it just is quite true that neuropsychiatric symptoms are omnipresent in people who have dementia. And if you follow people for 5 years with dementia, 100% of them will have neuropsychiatric symptoms. And these are the kind of standard neuropsych symptoms, blah, blah, blah. This is what I just said. But one of the other things about the NPI is it has 2 parts. It has the symptom severity, and then it has a caregiver distress. And that, I really like that because A, lets your caregivers know that you care about their distress. And if caregiver distress is less, that's actually many times more important than the severity of the symptoms, because caregivers are distressed when behaviors are directly impacting them or other residents. That, caregiver distress is an indirect marker. It's a different way of looking at severity. It's sort of the emotional impact severity thing. That's how I think of it. And it's super important. It's super important for staff retention. It's super important for in every way. So, and it's really important that our caregivers know, that direct caregivers, that we know that we really care about that their distress matters, because it is telling us about them, but it's also telling us about the resident and the environment. So it's super important. Okay. Aggression. The 2 most common times it happens, and I certainly have personal experience seeing this, it's when somebody is denied something, or or something is taken away from. So telling somebody no, like it doesn't work with the 2-year-old, and frankly doesn't work with most of us. We don't like to hear no, especially if we really want it. And if you take something away from me, like, well, A, you're stealing. I mean, B, really, how could you? And C, what does that mean? It means I'm powerless and you're powerful, and nobody likes to be powerless. Like, so there are many things that you can unpack from that, right? So that's one of the 2 most common times people are aggressive. And the second one is with personal cares. And, when somebody is physically assaulting me or trying to take my clothes off, or, touching me in my intimate private parts, I'm not too happy about that either. So it's not actually a big surprise that these are the 2 most common times people are aggressive. So figuring out how to work with people in these 2, so not denying people something and not taking it away, at least when they see you take it away, is really key. One of the things we had, I worked at a place, and we used to have a policy where we took people's medicines away from them if we didn't think they should be taking them. And so we had taken away somebody's Benadryl, and I got a call when the person went to the nurse's station, and she had a knife and she was about to cut her wrists. And she was very upset because we had taken her Benadryl away. This was somebody living in an assisted living. So the person ended up going to the ED briefly, and they sent her back. And so then we took off the knife. We took a lot of things out of her apartment, things she could use to, but we also worked with the staff about, like, people's belongings belong to them, and taking them is both technically and really stealing. So you actually have to get somebody's permission if they are living in a place like an assisted living. And so you have to negotiate with them and you have to talk to them and you have to like, why is this so this was the only medicine she had that helped her sleep. She had depression, she had major depressive disorder, she had PTSD, and she had terrible problems sleeping. And this was the only thing she'd ever found that helped her sleep. And yes, she didn't recognize it, but it was making her confused. Yeah. But so you have to figure out a different way. You can't just take something away from people. Okay. So, all right. Well, I'll talk about this really briefly. So Betty. Betty was a lady who came from Central Oregon. And Betty basically was attacking everybody who walked into her room. And she would chase people out. If you didn't leave, she would hit you. And she didn't talk much. She used to talk, but she didn't talk. She was a teacher, retired teacher. So anyway, she had been in the hospital for over 24 hours and nothing had changed except we had moved a roommate out. So we changed, but we couldn't, like nothing was working. And we'd never really had anybody who like totally was unchanged in 24 hours in every way. And she wasn't really eating or drinking. And it was just not, it was not a good situation. So I actually, in the late afternoon, I went and I sat outside her room in a chair and I noticed something that I had never noticed. Every single person who went into Betty's room asked her questions. Can I clean your room now? That was the housekeeping. Do you want your medicine? That was nursing. Do you want to eat? That was the CNA. I had walked in and asked her, how are you feeling? And she had chased me out, right? Every single person who entered a room started off with a question. Every single person. And what Betty would do is she would growl at us, she would chase us, and she would try and hit us if we didn't leave her room. And she didn't leave her room. So she didn't chase us out of the room, like past the room. She didn't keep chasing. She just got us out of her space. And I decided that my theory was that asking her questions was upsetting her. And so I tested it out. I went into a room and I said, hi, Betty, I'm Dr. Nash. You're Betty, and you're here at blah, blah, blah. And she just sat there. She didn't say anything, but she didn't jump up. She didn't chase me, and she didn't growl at me, and she didn't try and hit me. So I just backed out of her room without turning my back upon her. And I was like, okay, so we've now had, experience number one. So then I went over to the fridge and I got a thing of vanilla ice cream and I put a spoon in it. And I got her a glass of water, half of a glass of water. And I took that into her room and I set it down. I said, hi, Betty, you are Betty. I'm Dr. Nash. Eat. So I didn't ask her any questions. I told her who she was, where she was. I told her who I was, slowly, more slowly than I just said it. And I told her what to do and I gave it to her. And she ate. She ate the ice cream and she drank the water. And so then we came up with this care plan. The nurse, we had things pasted all over her room. Don't ask Betty questions. It was in her care plan. Tell her who you are. Tell her who she is. Tell her where she is. Tell her gently what it is you want her to do. Briefly, use as few words as possible. And we had signs everywhere. And within a couple days, she didn't chase anybody. Even the occasional person who still asked her a question, she would get very stressed, but she wasn't chasing people. And by the end of the week, she was walking around on the arm of CNAs or nurses or anybody else. She didn't talk. She was so loved by the town. She'd been a school teacher there. She didn't have any living family. They actually built her like a little ADU kind of thing on the grounds of the assisted living and took care of her, which I thought was pretty amazing. So everybody in the town knew her. They all, many people had been taught by her or their families had. So that was Betty. And that taught me questions when people are stressed are often the wrong thing. Short, do this, sit. Take this. Not do you want to take your medicine, but take this. There's just a world of difference. And my theory was that Betty, not only could she not speak, she couldn't understand. And so she just got terrified every time somebody asked her a question. And that was my interpretation. So that taught me a lot about questions. All right. What do these things mean? Sadness, crying, pacing, clenched fists, hitting, pushing away, calling out, screaming, being inconsolable. Well, think about pain. Always think about pain. The older we are, the more our joints have been moved, the more likely we are to have joint pains, the more likely we are to have diseases that cause us pain. Pain is really common. And if you look, the pain AD scale, which was developed for people with dementia, I recommend off-label use for everybody with brain diseases. If a person scores more than 5 on the pain AD, that means they're in pain. So you need to put that in the care plan. You have to figure out how to care plan around that. Sometimes there's medicines, sometimes there's other things you can do for pain. But think about pain. It's way overlooked, totally overlooked in people who can't use words to tell us what's going on. So, what are risks of ignoring neuropsych symptoms? Loss of placement, homelessness, lots of people get evicted, social isolation, being avoided by peers and staff. If you don't treat the symptoms, they're likely to get worse, and decrease quality of life, right? So you don't want to ignore them. And if you are sort of at a cross point and you can't figure out anything that is helping, reach out for help. And again, that's why the older adult behavioral health specialists, which are, there are representatives for every single county in the state. That's why they're a great resource. There's other resources. So you have to figure out what are your local resources, but it's really important not to ignore neuropsychiatric symptoms, and not all symptoms are treatable or changeable. So sometimes you have to recognize that. And the biggest thing there actually is calling out. If it's not pain, there are just some people who they have a switch in their brain stuck and they just yell out repetitively, frequently. And so that's an example of a symptom. If it's not pain, there's nothing you can do. Maybe put some music on. So that other people are less disturbed by it. And that might help the person. But that's an example of, it's not a dangerous behavior, but it really disrupts milieus and upsets people. But if it's not pain, there's no medicine for that. The only medicine would be, something that made a person unconscious, which we don't do. So brings us back to this therapeutic approach. Hopefully, I've described it enough. The next part of the training I'm gonna go over is some very specific things, and they, depending on your role, they may or may not apply to you, but treatment planning, just recognizing and correctly labeling behaviors, that's using the right language for things and everybody meaning the same things by the words they use. Adapting environments to promote so that people can do as much as possible. We all like to be independent. It starts usually around 9 months, and I don't think it goes away for most of us. We want to do it. We want to do, and we want to do it our way. As it turns out, most of us are like that. And that doesn't change just because you get a brain disease. And this is a unique one. Recognize that memory and orientation can be more intact than social and language skills. So, and you can see this, so one example would be kind of, there's some strokes and then a person can't use language in a meaningful way, but that doesn't mean they don't remember things or know where they are. It just means they can't speak and communicate, which can lead to lots of frustration and distress, especially if they're kind of very verbal people at baseline. Or they could have really impaired social skills if they have frontal lobe damage. And there's some illnesses that directly impact the frontal lobe preferentially. So that's a person whose memory may be intact and they may be able to do things, but their social skills are just, they say inappropriate things, they do inappropriate things. So that's why you really have to, just because somebody has some major impairment in one part of the brain doesn't mean other parts aren't working. And so that detective part of thing is super important. So don't forget that. And it's really helpful because if you can get people doing things, move them, distract them kind of from their lack of the ability to use language or their socially inappropriate stuff, get them doing something else that they're really good at. And so that's knowing what people did for a living or what hobbies they had, if you have that kind of info, or just sort of trying different things. But so that, people can stay busy doing something that they enjoy. And so their social disinhibition or lack of language is less troubling to them and to those around them. So recognize everybody can, has different weaknesses and strengths. And it's really easy to focus on the weaknesses because that's like our training is often about that. Certainly as medical providers, our training is to look for the weakness and try and treat it, try and figure out why and then treat it. And caregivers' focus is really on doing the caregiving, but remembering, just sort of that people, generally speaking, want to be independent. They want to do things their own way, and figuring out how to do things in a way that works for them is really key. Okay, then identifying appropriate communication techniques. There are rare occasions where reality orientation really is helpful, not usually, but it can be. Otherwise, validation, this is much more likely, validating people's emotions. So when people are anxious or sad or feeling guilty, they may actually have reasons for any of those feelings. And it doesn't really matter whether they have a reason or not. If they're feeling it, it's valid. So validating a person's feelings, and then sometimes moving right into distracting them. Because if somebody's entire family was killed, there's nothing we can do about that, right? We're not. So, and of course, a person would be very distressed about something like that. So validating that emotion, kind of meeting them there briefly, and then trying to move them on to something else. And that's a way of kind of using your executive functioning skills, your problem solving skills to move somebody into a less distressing place. And that's the kind of purpose of distraction. Educating family and caregivers, very, very important. And then setting realistic goals, always helpful to be realistic. Certain psychiatric symptoms are amenable to treatment with meds. These things are very treatable: paranoia and delusions, hallucinations, sometimes depression, if it's a depressive illness, sometimes anxiety, if it's an anxiety illness, but depression and anxiety as natural reactions to things that are either depressing or anxiety provoking, there's no medicine for that. And most anxiety in older adults is not an anxiety disorder. It is usually a mismatch between what the person wants or can do and what is being asked of them. Pain is treatable, usually, though not always. Agitation really depends on what the heck you mean. If you're talking about aggression, yes, we have medicines that help treat that. If you're talking about pacing, it depends. Sometimes it's treatable. And sleep challenges. Sleep is like the number one complaint of older adults. Even when people, as near as we can tell, really are sleeping at night, many people, in fact, most people will tell us they didn't sleep. And I usually take that to mean they didn't sleep well. And yeah, we can try melatonin. I'm not a big fan of most other sleep medicines unless a person has another psychiatric illness. But melatonin might work as far as meds go. Symptoms that are not usually amenable to meds. So wandering, 100% never. No medicine handles wandering unless it makes a person comatose, again, illegal, unethical. So wandering is not treatable with a medicine. Never give somebody a medicine to try and prevent wandering. Never. Do not do it. It doesn't make sense. It's illogical. Calling out. If it's not related to pain, it is not usually like giving someone a medicine. There is no medicine. They have a part of their brain that is stuck on, and there's like, you can't turn it off without turning the brain off, which is usually called killing somebody, which we don't do. Repetitive questions. Well, that usually just means the person didn't know they just asked the question. So for them, it's the first time they asked the question. And so even though it's a challenge, we have to answer it like it's the first time they asked it. And it doesn't help to tell them that we already answered that question. Like, that is the least useful thing to say. And it's really hard as a person to answer the same question 10 times. If it's your spouse, you're lucky if you can it can be tolerated twice. But for somebody with dementia, repetitive questions, sometimes you just have to find a different staff member. Let me go get Sally and see if she can answer that. If you just can't take it anymore, right? So you have to work around it. And that's where the distraction can come in very handy. But there are no meds for that. Anxiety related to having memory loss. Like, you can't treat that. That's not an anxiety disorder. That's real. 1/3 of people with Alzheimer's disease have good insight into that. They're very unhappy usually. Not always, but often. And they're very anxious. You can't treat that with an anti-anxiety medicine. You treat that by working with the person's environment and kind of validating and distracting. Psychomotor agitation, often not amenable to meds. Sleep problems. You know, do you know what the best treatment for sleep is? There's two things that are really good. And they're hard because not everybody can do it. Exercise in the morning, walking is the best one. If we could get people to get, 10, 15, 20 minutes of walking in a couple times a day, they would sleep much better. What else? Bright lights in the morning. Those are the only two really good evidence-based ways to help sleep problems in people who don't have a primary psychiatric disorder or neurological disorder that affected their sleep center. And for most older adults, it really is lack of activity. Exercise cannot be underestimated. And if people can't walk anymore, it's really hard. But sometimes they can do upper extremity things. And so working on that. But that's actually the best thing for sleep. Agitation depends on what you mean. Often you just need to change the environment, change your caregiving approach. So this is the general approach for combativeness. Treat pain. Use the pain AD or other scale regularly. The 1 to 10 pain scale is not at all useful in anybody who has a brain disease. You can do it, but you can't really rely on it. You have to really use something like the pain AD. You have to look for the behavioral signs of pain. Breeding constipation. Constipation is rampant, underestimated. We actually are all supposed to be drinking around 3 liters a day. Most of us don't even come close. Older adults in facilities definitely don't come close. So hydration, prunes, oatmeal, #1 treatment for constipation. #1. #2 is exercise, regular exercise. #3 is hydration. And then otherwise prunes, anti-constipation meds, but and then if somebody has taken lots of meds their whole life for constipation, like if they've done that for 5, 10, 15 years before they come to your facility, their bowel probably doesn't work anymore and they need to be on a stimulant medicine. I mean, there's just no way around it. But for people who haven't already sort of trained their bowels that way, then you need, this kind of approach can help. At the moment, a favorite food can interrupt combativeness. Now, obviously, that depends on what stage we're at in the combativeness. Like when if somebody's trying to hit somebody, that's not the time to say, here's your shake. But kind of before you kind of get to that escalated moment, a favorite food can be a nice distraction for certain people. Consider urinary retention. You'd be amazed how people act when they have 2 liters of fluid in their bladder. I have seen a Foley catheter or a straight cath treat combativeness on numerous occasions. So how would you know that? Well, you'd really have to kind of be in tune with their what they've been doing. But they're also, if they have certain diseases, like if they're on anticholinergic meds or if they have BPH, there's certain things that increase your odds of urinary retention, and you really have to pay attention there. In the moment, taking them their favorite beverage. So for me, I try and drink lots and lots of water, and I drink 2 to 3 liters a day. And so when I get to that point, if somebody says, oh, Maureen, it's time for your water, that actually could work because it is overlearned behavior and I've been doing it for decades. And so it might work for me. So if you have something like that, other things, let's go for a walk, or let's go listen to some music, or whatever it is that they like, if they can do it. So, those are all sort of in the pre-actual combativeness. if people have calmed down and they are a kind of person who enjoys socializing, and this is probably 65% of people or so. There are other people who really just do better with being alone. And people fall into distinct camps from a young age. But if they are a person who kind of likes socialization, who enjoys it, who seems to benefit from it, if you can get them calm for a bit, that's a great way to distract. And this is where experienced caregivers, you know, they're better at sort of sensing that. But big one here, fewer or no questions. There's a world of difference between saying, are you in pain? And you look like you hurt. One's a question, and one is a gentle, calm statement. Let's go get X. Do this. Sit down. Gentle, calm statements. Don't ask questions when people are upset. Now, if people start talking about why they're like if you're kind of in that spot where they can have a conversation, some questions can be helpful. But the more impaired a person is, the less helpful questions are. And you just have to make an educated guess. You look hungry. Let's go eat. And then if you do have a question and you want to offer somebody choices, never more than 2. Just don't do it. Yes or no, not great. This or that, much better. And why is that? Well, because questions are stressful. Questions take the ability to think things through. And if you're asking questions, like if you're not just offering this or that, the cognitive load is actually pretty significant. And we under recognize how stressing that can be, especially for people whose brains aren't working well. So avoiding questions, using gentle, calm statements, gentle commands. And if you're going to offer choices, this or that, not yes or no. Because A, if they say yes or no, you don't know if they actually mean yes when they say yes. And B, you know, it doesn't help you kind of get to the next. It's a close-ended thing. It just sort of ends at yes or no. Whereas this or that is different. All right. So something about psychosis or severe behavior disturbance in dementia. It independently predicts mortality regardless of treatment with antipsychotics. There are medicines that are off-label and on-label to treat both psychosis and severe behavior disturbance in dementia. There's things that really work and that work well, and there are things that are FDA approved for that now that are antipsychotics. So this is sort of a factoid for people to know, because there's a lot of myths and misinformation and just fixed false beliefs about this class of medicines. And antipsychotics are not tranquilizers. And there's a long, sad history between why people think that they are, but they aren't. And that's not why they work. And that's not, generally speaking. I have used antipsychotics as a tranquilizer one time in a person who had such a severe heart attack that we couldn't let him wake up. It's the only time I've ever used an antipsychotic. as a tranquilizer, and the person I wasn't treating psychosis. It was a very unusual circumstance because most people don't have such a severe heart attack that waking up could kill them, because most of the time that person would just be dead. But this was an unusual situation. Okay, dementia specific meds. If you have Alzheimer's disease, vascular dementia, Lewy body dementia, Parkinson's disease dementia, if you have vascular dementia, if you have any of those things, dementia, cholinesterase inhibitors are the #1 most effective thing to treat behavior disturbance. Cholinesterase inhibitors treat psychosis, agitation, paranoia, delusions, apathy, depression. So memantine treats sleep, appetite, anxiety, agitation, aggression. And I realize there's probably not a lot of prescribers in the audience, but I'm just reviewing some of the things just so you have some background information. What is more dangerous? Is an antipsychotic more dangerous than an antidepressant? What about a benzodiazepine? What about atypical antipsychotics? You know, the old ones, the new ones? Well, it turns out actually atypical antipsychotics are safer than benzodiazepines, antidepressants, or antipsychotics. They just are. The data is clear, and the world can be an odd place. And there's a lot of people who have odd beliefs. Sometimes the majority of people have odd beliefs, but this is data. What really works? Well, here was an interesting study. Is it human contact or is it the intervention? So they were looking at decreasing verbally disruptive behaviors. So social contact led to a 56% decrease in verbally disruptive behaviors. So it's just the staff member being there, or a peer, or a family member. A videotape of a family member speaking to the person led to a 46% decrease in verbally disruptive behaviors. Getting it on an iPad, getting it on a TV, one way or another, VHSs are really old school, even CDs are old school, but sometimes a DVD can be the way to go, even if it is old school. Music led to a 31% decrease in verbally disruptive behaviors. And not doing anything, well, 16% of people just got better. So sometimes just letting people alone, it will go out on its own. So it really depends. So this is one of the studies. There are lots out there. Really, caregivers and caregiver training, caregiver education, caregiver support. There is nothing that compares to that. That's where the bang for the buck is. Other things show a little bit of benefit. Almost all the studies showing significant benefit or even moderate benefit from all the other things, that all those studies are all in people with very mild dementia. And most people with mild dementia are not living in residential care. So it's not that they don't help some people, but they're unlikely to help residents in residential care in the state of Oregon. So what is caregiver education that I've been talking about so much? Well, providing direct caregivers with the right tools. It's amazing what the right tools do for all of us. Caregiver support groups to decrease stress and improve the quality of life of your caregivers. If your caregivers feel supported, it's not rocket science. Actually, if we feel supported, we're able to support other people. It's just kind of, I don't know, maybe common sense. Designing, whoops. Let me see if I can't even see the whole part of my slide. All right, designing and providing stage-specific treatment plans. So the treatment plan needs to change as the person changes, and evidence does change over time. And remember, evidence is based on clinical expertise, and that's great. But at the end of the day, we're all an N of one. We're all a unique case study of ourselves. So if you find what works for me, then keep doing it until it doesn't work for me, and then try and find plan B that works for me, so to speak. So using this whole thing, we were able to, at the Tuolity Center for Geriatric Psychiatry, we were able to significantly decrease caregiver burden. This is data from 390 consecutive patients. So caregiver burden went way, way down during an admission with an average length of stay of 10 days. And symptom severity went down. But you'll notice that symptom severity, like caregiver burden, went down further than symptom severity did. Symptom severity definitely almost went in half for most things. So that's great. Symptoms are treatable. But if you treatment plan correctly, caregiver burden will go down more. And it's really super important that caregiver burnout from aggression in particular be low. That is key to quality of life for everyone, including the resident. Little bit about end-of-life illness. If you look at this bottom graph, most people with frailty or dementia, the phrase that this study used is prolonged dwindling, which is really different than cancer or like heart failure or COPD/lung failure. So it's sort of something just has to happen. It's usually unrelated directly to the frailty or the dementia, and that's what leads to death. And so there's this long period where sort of a person's abilities decreases. And that's why caregivers are so very important. I'm a big fan of the mini suffering state exam. Just looking at my watch here. It's a very simple tool, and I really like the questions. Is the person calm or not calm? Screaming or not screaming? In pain or not in pain? Do they have decubitus ulcers or not? Are they malnourished? And the biggest explanation is sort of, are they losing weight? Are they not eating? Are they needing frequent blood tests or ED visits, including for behaviors? Do they have an unstable medical condition, pneumonia, electrolyte imbalance, And then the two most important questions: is the person suffering in medical or nursing opinion? And then is the person suffering in family or sort of whoever is the closest thing to family that a person has, if hopefully they have someone. Do you believe that your loved one is suffering? So it's just 10 yes or no questions, pretty simple, pretty straightforward. Some of them are just based on data. Most of them, the last two are really important. And I think they're most important because just ask, do you think your loved one is suffering? Do you think your mom is suffering? Like just asking that question, I have found changes how many families think of things, and they stop getting focused on details, and it helps people take a step back and looking at the big picture. And in my opinion, the big picture is suffering. And what I want to do, I see my job as decreasing suffering where possible, or supporting people and their loved ones if suffering isn't treatable. And the mini suffering state exam score in people with advanced dementia, it is very predictive of death, but even in anybody, it is helpful to see a low level of suffering is a low score, a high level of suffering is 7 to 10. In studies that, people are pretty good about rating most things similarly. There's always a high level of disagreement on calmness because it depends on when you look at the person, and suffering according to physician or nurse's opinion. And I think the farther away a person is, the harder, their judgment. There's a lot of things that go into your personal assessment of somebody else's suffering. But in people who have advanced dementia, or who are in an ICU, the mini suffering state exam predicts mortality very well, and a high level of suffering, a mortality rate of 120 days. And I have found in my practice that this is a pretty good scale. And again, it's shifting the focus to whether a person is suffering seems to really help. And so I really like this tool. I use it a lot. I just want to point out antipsychotics for agitation. There are studies, especially older studies, that suggest, maybe they're not really helpful. And the key challenge with those studies is every study used a different definition of agitation. And that's the problem. More recent data, antipsychotics for aggression and psychosis, which is what I recommend antipsychotics for. There's even one that is FDA approved for agitation and aggression in Alzheimer's disease. And the AHRQ, which is a federal quality, they actually did a really nice review of the evidence. And what they found is where the evidence is, antipsychotics have the most evidence for dealing with aggression. Number one, compared to everything else. And then the next thing is caregiver training. And there's really not a lot of evidence for other things. That's what they found looking for sort of lots and lots of evidence. They didn't really look at dementia-specific meds. So can we predict what is likely to happen if we just take people off antipsychotic meds after that has helped them? Well, it turns out we can predict. Most people, the vast majority of people, relapse. So, and the shorter the period of time they're treated with an antipsychotic, the less likely they are to not relapse. So there are lots of people who need to stay on their antipsychotic. Just a brief, I did talk to the head of the FDA back in 2012, the top two psychiatrists at the FDA, about the specific warning that is on antipsychotics about the risk of stroke and death. And I pointed out to them that all the data showed was an association. None of the data showed antipsychotics cause. They actually said, yes, you're right. And I said, but your warning implies that they cause it. That's how everybody interprets the warning that is placed on antipsychotics. And they said, well, that's not our problem. And then that's when they said, we don't understand the signal. So they were saying, I don't know why antipsychotics and death are related in people who have dementia. And they agreed with me when I said, well, I looked at the data and, you weren't looking at people who were appropriately treated with antipsychotics for psychosis or aggression. And they said, yes, that's correct. And then I said, and you didn't exclude hospice patients who were dying and 100% of hospice patients are prescribed Haldol for end-of-life delirium and for nausea and vomiting. And so that is always going to skew any large database. And they said, well, yes, that's true. They weren't, and then they said to me, well, you know, the risk is really highest at the start of treatment. And I said, yes, I know that because I'm an expert in the field, but people don't know that. And so they said, maybe there's an increased risk of sedation, but you know, they didn't have any evidence for that. And we don't have any evidence for that. And there's just no evidence for that. What about aggression and severe psychosis predict death? We do have evidence that that's true. And then they said to me, the box warning is not a contraindication to using these medicines. And I said, well, I know that, but people don't know that. Everybody thinks antipsychotics are wrong. And personally, I think that is one of the great travesties that has caused untold suffering in people in the United States. Here's the therapeutic approach. It works. Keep it up. And you're already doing some of it. We can all do it better.
Thank you so much, Dr. Nash. That was an awesome training. You will all receive Dr. Nash's slide deck and an evaluation for the NASW CEUs in a follow-up email, as well as our next training. Is there any other questions today? Okay, well, I guess that wraps it up. Thank you all for your time, and we hope to see you next month.